Hello everyone, I am Zarmeen Nasim, working as a senior instructor at the Al Khan University in Pakistan. And today I am very excited to present a research study on clustering patient complaints presented to the ER. And I am very excited to be a part of NLP Summit, and I hope that you are enjoying NLP Summit already. And just I would like to briefly introduce myself. I did my PhD in computer science and with a focus on natural language processing, particularly for social media feeds. So at the Al Khan University, that is a medical university, here my job is to basically work on clinical data sets and apply some data science approaches to create some data driven decisions and workflows. So, in emergency healthcare settings, the ability to rightly interpret and handle the patient complaints is of immense potential. Clustering based approaches help us to identify the unique patterns that exist within the data sets consisting of textual or non textual documents, data sets. So why we need to do clustering? So clustering help us to identify the common patterns. It help us to optimize the resource allocations at the healthcare settings in order to make sure that the patient receives the right care at the right time. Also, it helps us to early identify the potential outbreaks by seeing the fluctuating frequencies within the clusters. And it helps us to devise some targeted treatment strategies. So the major research objective in this particular study is to analyze and understand the patterns and clusters within patient complaints that are presented to the ER. So the sub-aims were to identify the hidden patterns and some associations, and also we are trying to investigate the distribution of clusters over time. So we want to identify that whether seasonality has some effect on the distribution of patient complaints within certain clusters or not. The third is to basically we want to gain the insights into potential impact of clusters on making triage decisions. So which type of patient complaints receives this high priorities during the triage processes, and which type of complaints receives the lowest priority during triage decisions. And the fourth sub-aim of this particular study is to understand the patient outcomes, such as mortality, length of stay across different clusters. So this is how we developed our methodology. So the input consists of the data sets containing the patient complaints. So patient complaints are the textual document, textual in the form of words that captures the presenting symptoms reported by the patients at the ER. Then we need to perform certain text pre-processing that involves resolving the acronyms, removing the noise from the text. After doing the text pre-processing, we need to further extract the symptoms and comorbids from the patient complaints. After extracting the symptoms and comorbidities, we then applied K-means clustering to identify the clusters within the patient complaints. Once we did K-means clustering, we then interpret those clusters and identified that there were certain clusters that have similar kind of distributions. So we tried to merge those clusters based on the similarity in the characteristics exhibited by those clusters. And the final step, that is the most critical step, was to basically interpret those clusters. So patient complaints is a kind of a free-form text that is recorded by the nursing staff who is present in the ER, and it captures the primary concerns, symptoms, or the reasons for seeking the medical care as reported by the patients when they visit the ER. So there were certain characteristics exhibited by those patient complaint. The very first and the most critical or challenging thing is that it is a very short length text, consists of at most 10 to 12 words, and it contains symptoms and existing comorbids in the patient. So here you can see on the slides that I have put down certain examples of kind of patient complaints we see in those data in the ER data set, such as loose motion and vomiting since 2 days, then fever since yesterday in evening, known case for IHD, HTN. So during the text pre-processing, what we need to do was that we need to resolve certain acronyms such as IHD into ischemic heart disease, HTN as hypertension, and you can see that there are certain kind of noise such as R's several question marks. In the fourth example, you can see that we see a Urdu word ghabrahat. That's basically the Urdu word written in English language that shows the uneasiness felt by the patient, usually in the chest pain cases. So we have these type of patient complaints in our data, and our data set was almost contains about 50,000 patient complaints. So during the feature extraction, we used BERT-based uncased clinical named entity recognition that was available on Hugging Face. And that model was used to extract the symptom, treatment, and tests from the patient complaint. And we use these things for as our features for clustering process. So loose motion is the problem, vomiting is a problem, shortness of breath is a problem, COVID PCR is the test. Similarly, IM injection rabies vaccine is the treatment. Then for the clustering is the basically unsupervised computational approach, and there are several algorithms available, but the most widely used method is k-means that we applied in this research study. Here in the k-means algorithm, we need to provide the value of k. So in order to determine the optimal number of clusters, we plot this elbow method. We plot this elbow curve, and this curve shows that 30 is the optimal number of clusters. So we started off with 30 clusters, and we applied clustering using the 30 clusters. This plot shows the distribution of patient complaints across clusters, and this shows that the cluster 11 contains the maximum or the highest number of patient complaints. And this cluster usually, when we dig it down further, we observe that this cluster contains complaints of chest pain, vomiting, fever, and shortness of breath. This is the distribution of age across clusters, and here we try to identify the difference in the age distribution across clusters. Here you can see that in cluster, for instance, in cluster 13, the median age was 38 years, and when we further try to investigate what type of complaints were present in this cluster, it shows that this cluster contained the complaints of road traffic accidents. So this shows that mostly the young adults were basically suffered in those road traffic injuries. Similarly, we also try to see the distribution of respiratory rate and saturation of oxygen that was measured through the pulse oximeter in the ER. And here you can see that the maximum value of respiratory rate and saturation of oxygen was observed in cluster 4. And when further investigate what type of complaints were present in cluster 4, we found out that it mostly contains the complaints of shortness of breath and COVID-19. Then we also try to see the distribution of triage categories. So in the ER of the Khan University Hospital, there are 5 triage categories starting from P1 to P5, where P1 represents the most severe cases and P5 is the lowest priority cases. So you can see that the clusters such as 29, cluster number 29 has uh, vast has a very high proportion of P5. And when we further try to investigate the complaints, it came out that this cluster contains mostly the complaints of the patients who were visiting the ER for getting certain type of vaccines or injections. That's why they have been assigned as lowest priority. Similarly, the cluster 13, which is which contained the complaints of road traffic accidents, has the high proportion of P1 category. So when we discuss these numbers or these results with the clinicians had a hard time to basically understand the clusters due to the high number of clusters. So we tried to merge these clusters as a part of a post-processing operation. So what we did is once we applied on the k-means clustering on the full patient complaints data set, we then try to calculate certain characteristics of those clusters, such as 50 most frequent words, what's the median age of the cluster, percentage of female patients, percentage of patients with P1 triage category, percentage of patients with P5, that's the lowest triage category, and percentage of mortality within the cluster. So these six features were then used for clustering purpose, and we then run a second round of clustering using k-means on those six features to basically merge those clusters. And when we plot the elbow method, it was found out that 10 is the optimal number of clusters. So what we did is we merged those 30 clusters into 10 clusters based on these six characteristics. So this slide shows the word cloud of different clusters, the 10 clusters that came out after merging the initial 30 clusters. So cluster 0 shows the complaints of the patients who were visiting the ER for vital sign checking or to get certain kind of injections or vaccinations. Similarly, cluster one has the patient complaints related to hypertension, fever, weakness, cough, and these type of things. Similarly, cluster 9 has the majority number of complaints related to chest pain, shortness of breath, vomiting, fever, and the patients have the comorbidity of hypertension. So in the 10 clusters, this is the frequency of patient complaints in each cluster, and showing that cluster 9, which is related to chest pain, fever, vomiting, has the highest number of patient complaints. Then, as a part of our primary objective, we try to identify the distribution of patient outcomes across these different clusters. So we calculated the odds ratio to identify to determine the association of the clusters with mortality. And it came out that cluster 2 has the highest has the highest odd ratio of mortality. And when we try to interpret the cluster number 2, this is the cluster of patient complaints reporting the COVID-19 and shortness of breath complaints. So the data set was of year 2021, so we can expect the COVID-19 cases in that year. Then one of our aim was to determine the effect of seasonality on those clusters. So what we tried to do was trying to identify that whether there are certain type of patient complaints that arose in certain seasons, or the season does not have any impact on the distribution of those clusters. And it came out that across those clusters, we see the uniform distribution across month-wise. So this plot actually shows that the seasonality has no impact on the distribution of complaints, and each type of complaint is seen during the whole year. So I would like to conclude my talk with these key takeaways that the clustering analysis that we did is quite helpful to basically identify the kind of patient complaint that we receive in the ER. And the motivation is to basically identify the to basically identify the what kinds of complaints we are having at our ER, so we can do the resource allocation in an optimized fashion. And we try to basically uncover the distinct patterns within the patient complaints, what kinds of age distributions we are seeing across different complaints. So, for instance, in cluster 13, we see that the cluster that is associated with the road traffic injuries has the median age of 38 years, which shows that young adults are having those road traffic injuries in majority cases. And this work actually shows the potential of the data-driven decision making in emergency healthcare, and we are very hopeful that the AI-based approaches and natural language processing-based techniques can be very helpful in uncovering the patterns that we see in the clinical data sets. And we all know that the clinical data sets have a vast majority of unstructured data sets in the form of clinical notes, in the form of discharge summaries. And these type of computational techniques and data driven techniques are very helpful in transforming and revolutionizing the emergency healthcare. And thank you very much for having me and listening me. And I will be very glad to take up any questions if the audience have any. So the floor is open for the questions. Thank you very much.
This was the last presentation today, and I'd like to thank all the speakers for their excellent talks covering state-of-the-art NLP and LLM applications in healthcare and in life science. Today's session highlighted the following takeaways: the healthcare GPT model benchmarks, the transformative impact of generative AI in drug discovery, advancement in diagnostic medical reasoning using LLM and AI systems, strategies for leveraging healthcare NLP in medical centers, and discussions of how we all as a community can work together towards responsible AI with the Coalition for Health AI. These discussions collectively offer very valuable perspective on enhancing healthcare outcomes through AI innovation. I would also like to say a big thank you to all of you, to this amazing community, to each one of you personally for joining and contributing with your own experience. See you tomorrow.